Welcome to the Jack Westin MCAT podcast with your host, Phil Hawkins.
And Azaii Calderón Muñiz.
Hello, welcome back to the best podcast that you can listen to studying for the MCAT or otherwise. And so today we're excited to talk about a topic that we have not spoken about yet. It's a topic that is important, not just for the MCAT and the bajillion ways that they can test you on it, but also for you as future physicians. And today we're talking about the cardiovascular system. So yes, the MCAT can test you about it in lots of different ways, right? There's the connection, of course, to the cardiovascular system, the connection to the respiratory system, connection with acid-base metabolism, muscles, you name it, they can test you on it, right? Endocrine system, neurology, right? Nervous system. So pay close attention. We are excited. And just, we talk about it, right, with respect to the MCAT, but also cardiovascular disease, something related to the heart is actually the number one cause of death in the United States. Second is cancer, and third is COVID. And so despite all the losses that have occurred in the last few years, cardiovascular disease is something that we still need to be talking about actively with patients, right? You guys in the future, prevention is really important before it even becomes an issue, right? So we're very excited to talk about this today. We'll just dive right in.
Yeah, I just want to echo, this is insanely high yield. And as you mentioned, it's easy for the MCAT to cross this over into the topics, like all the stuff you talked about. Also, like nephrology, like what's going on with the kidneys, which helps do stuff with blood pressure, but also like chemistry and physics. And so there's a lot of stuff with like fluid dynamics. Like that's something the MCAT expects you to know about. What is the single easiest way for them to test that in a medically relevant way? Cardiovascular system. So a lot of times you see cardio, not just in the biology section of the test, but also the chemistry and physics portion of the test. And so that just makes it way higher yield overall. But I think when people hear the term cardiovascular, they think heart, right? I want to at least start off by focusing on the vascular side of this. Your vasculature, that'd be like your arteries, your capillaries, your veins. And so this system obviously all works together, but very often a lot of the problems that we have with the cardiovascular system are not necessarily heart problems, but more vascular problems, more problems with vessels. That's like high blood pressure, like that is like due to what's going on in the vasculature, not necessarily what's going on with the heart. And then like blockages, heart attacks, strokes, all of those are more vascular related. So we're going to focus on them a little bit to begin with. As I mentioned, arteries, veins, capillaries are the three main parts of that. Arteries are what's carrying blood away from the heart. Then they go to capillaries, and then they go to veins, which go back to the heart. Now that's generally speaking, there are some weird exceptions where it'll go like artery, capillaries, vein, capillaries again, vein, and then back to the heart. But like that's kind of a weird thing. It does happen in a couple of places in the body. Like we call that a portal system. But for the most part, you can just kind of think like arteries, capillaries, veins, back to the heart, and then repeat over and over. But there's some big differences between these structures. Arteries are really muscular. They have like these thick muscular walls, smooth muscle in there, not cardiac muscle, although obviously there's a relation here to cardiac and heart stuff, but it's smooth muscle. That smooth muscle needs to be there for a couple of reasons. One, like those thick walls have to be there because the artery is dealing with like really high pressures because the blood is being pumped straight from the heart into the arteries. And so your arteries need to be able to withstand that high pressure. But arteries also help us control blood flow and direct blood flow. Like if I see a bear and my sympathetic system activates, I'm going to dilate to my arms and legs. So I'm getting more blood and more oxygen to those for running and kicking and punching. But then I'll vasoconstrict to like my intestines and my like digestive system because I don't need to send much blood there. And so arteries, this ability to kind of like dilate and constrict, allow us to shunt and move blood in different proportions around our body as needed, which is pretty sweet. It's actually kind of a cool thing overall. After that, capillaries, which are tiny. The walls of capillaries are one cell thick. They're like really tiny. Generally, there's enough room in a capillary for a single red blood cell or red blood cells to go like single file. So they're very tiny. There are a ton of them though. And so especially looking at fluid dynamics, like your one artery branches into like thousands of capillaries or tens of thousands of capillaries. So even though each capillary is small, the total cross-sectional area of capillaries is bigger than an artery. And so as a result, the velocity is less. So blood actually is going slower in the capillaries as well. That takes us lastly to veins, which are, like, they're pretty simple. Like veins don't have much like a thick muscular wall. They're a little bit different. So if in anatomy lab, I was always surprised. I thought I would have trouble telling the difference between an artery and a vein, but it's so easy to tell the difference between them, especially if you can touch it, right? Because veins, like imagine you had like a straw or a tube that was made out of like cloth, right? Like if it was filled with water, you could like squeeze it and it would like squeeze really well. A lot of times arteries feel like cords, right? Where like a solid thing because they're so muscular, like you can't really compress them overall. So veins are like big and like the walls aren't really muscular. I will say something interesting about veins is that they have valves. And so something that lets blood only go in one direction. This is really important for like the blood in your veins getting, or in your like legs, getting it back to your heart. So when blood comes up, it can't just go back down because gravity is pulling on all your blood. And so as a result, you kind of want to just have all your blood in your feet because it's all being pulled down. And so those valves help kind of like keep blood moving in one direction. And that's a kind of a particular special thing that veins have going on that don't exist in the other ones.
Yeah. And a lot of times I hear students asking, and not just about this topic, but a lot of MCAT topics, why do I need to learn this? I'm not going to use it as a doctor. Yes, you will. So ultrasounds, right? You can tell the difference between an artery and a vein on an ultrasound. And that's important when you're trying to figure out, you know, what structure you're looking at. Is it being well perfused, right? Is it getting good blood supply or not? This is something that if you go into OB-GYN, right, you're going to be looking at umbilical cords every time someone gives birth, right? And you have to count and make sure that there are the appropriate amount, artery and vein, right? This is something that is just so important. If you decide that you want to be a surgeon, when you're doing laparoscopic surgery, right? Tiny holes and using a camera, you can tell the difference between an artery and a vein by putting the instrument up against it and seeing if you can feel the pulsatile nature of an artery. So across so many specialties, this is going to be important, right? And having an idea of what's going on is just so key. And I think it's really easy to lose sight of that when you're studying for the MCAT, just getting really frustrated. Like, I'm not going to use this as a doctor. You will.
I like that you connect that to surgery because like if you cut an artery, because it's under such high pressure, blood will squirt from that. And it is really hard to stop the blood from coming out of it. Imagine you have like a pipe with really high pressure. If you pierce that, everything is trying to leave and get out of there. Veins, like the pressure isn't as much. And so if you were to nick a vein as a surgeon, that is a much less severe of a problem versus nicking an artery. Just side note, it's a really cool, interesting thing about the way the human body works and is designed. Mostly like our arteries are deep inside of our body and our veins are on the surface. So when you like cut your like arm or leg or something, generally speaking, like when you're bleeding, it's coming from veins and capillaries. It's not coming from arteries because like in my arm, the artery is like at the very center of my arm. But the veins are all on the outside. There are a couple of places where arteries are near the surface. Like right in like the armpit, there's a place there, or like right in the like your kind of crotch groinal region, your femoral artery is on the surface there. And so there are times when people will have, or your carotid arteries in your neck. And if you are in a wreck or an accident or something and you cut those, like that's a much more severe problem than cutting veins. And so this is something that like surgeons and emergency medicine stuff, like they're paying really close attention to, like, because if the difference between artery and vein may be the difference between life and death in this case. So something you want to make sure that you are aware of. Like, I don't know about you, Azaii, but I like when I was doing anatomy lab, it always surprised me. Like there were times where I couldn't tell the difference, especially when I was starting, like the difference between a neuron, like a nerve, and then like an artery, like, because they're both like roughly the same color. They both like won't like compress very well. It's a lot easier when somebody's living because blood is flowing and it's pulsing. But in a cadaver, it's kind of hard to tell the difference between a nerve and an artery. Vein, once again, super easy, just because the structure of them is so different from arteries.
Yeah, it's so interesting when you get to that point, and hopefully you guys are excited about getting to that point as much as we're excited about talking about it. It's also really important not just to know the difference between these vessels, but to know the paths that they take, right? And so just kind of taking a step back, thinking about how blood flows in the body. So you have blood right in your body, at your organs and different parts. And so they have to make it back to the heart, right? And so at this point, they're oxygen depleted. And so the blood is oxygen depleted. So there's not a lot of oxygen. So it gets to the heart, but then it needs to get oxygenated, right? And so it's going to leave the heart and go to the lungs where it's going to pick up oxygen. And actually, really cool, part of the reason why, if you think about it, why having these cells go in a single file line in capillaries is so that there can be good diffusion, right? And so you can have the transfer of oxygen, for example, effectively. And so you don't just have red blood cells running past without picking up oxygen or delivering oxygen at the level of different organs, right? So really important to keep track of. So now it's in the lungs, it's picked up oxygen. You need to get it back out to the body, which means you have to stop at the heart first. And so body, heart, lungs, heart, body again. And once it leaves the heart, right, after it's gone to the lungs, comes back, leaves again, now it has oxygen. And so now it's ready to go do its thing, deliver what it needs to deliver, right? I want to really quickly point out that, like you said, Phil, arteries they're going to leave the heart, veins come back to the heart. And normally a lot of students, they'll think, oh, red artery, right? It's oxygenated. There is an exception to this, and that's the pulmonary artery, right? It's leaving the heart, but it's not oxygenated. So little tidbit to keep in mind. So now we'll focus on the heart itself, right? So imagine that you're this red blood cell and you have made it to, let's say, the liver, right? And so you've dropped off the oxygen that you needed to drop off at the liver. And so now you're empty. So you're just making your way back, right? You're trying to get back to the heart. So let's say, since you're coming from the liver, you'll go in through the inferior vena cava, right? So vein, and we're coming back to the heart. And so now we're at the heart. Where do we go in? So you need to go in. This is counterintuitive. You go right to left. So you're this red blood cell, you've dropped off your oxygen, you're coming back to the heart. So you're going to stop at the right side of the heart, and A comes before V. So the atrium comes before the ventricle. So you go into the atrium, right? And now you've run into something. And so what you've run into is the tricuspid valve. So it's like a gate. And so you need to make it past the gate into the right ventricle. So we've done drop off oxygen at the liver, come back to the heart, right through the inferior vena cava. We've made it to the right atrium, and now we go past the gate into the right ventricle. But you've already dropped off your oxygen. You're empty. And so you're going to go to the lungs, right? Pulmonary artery, you go to the lungs, hit those capillaries, and you're going to pick up the oxygen, and you're going to make your way back to the heart. But we said right comes before left. We've already seen the right side of the heart. We come to the left side. So now you have this oxygen on your back. And so you make it to the left atrium. And so you're at the left atrium, but there's another gate, right? You need to make it past the gate. And so this gate is going to be the mitral valve or bicuspid. And so you come through the gate, you're in the ventricle, You come out through that ventricle because you have that oxygen on your back. You're ready to go, right? And so you're going to come out through the aorta and you're really excited and you're going to make your way to whatever organ you decide. And so recapping, right? You go, let's say liver. So you go to the liver, drop off your oxygen, drop off your package, come back into the heart, right side before left, atrium before ventricle. And now you need to pick up some oxygen. So you go and you make it to the lungs. You come back to the heart. Now you're on the left side, A before V. You've made it past 2 sets of gates, and then you leave through the aorta and you are happy. You have your backpack full and you're ready to go deliver your package.
Yeah.
So
it's a little bit tricky, but like visualizing this and kind of imagining that path, I think does help. I totally like just kind of like imagine like, oh, I'm missing something. I'm going. I like that exercise of just trying to think about like if I was a red blood cell. I think it's a really good way to kind of put that together.
There's also a really cool mnemonic to remember the valves. And so that's lamb rat. So left atrium is going to be the mitral valve. It's also called the bicuspid valve. And then rat, right atrium, tricuspid valve. So if you ever get stuck and you're figuring out, okay, which valve is where, just think lamb rat.
Yeah, it's a little bit like the mitral valve. Like a lot of students get confused between the bicuspid and mitral. Like they're the same thing. Somebody like some anatomist way back in the day looked at it and like said, oh, there's 2 cusps to this valve. So we'll call it the bicuspid. That makes a lot of sense to me. But then some other anatomist was like, hey, that looks like the Pope's mitre, which is actually the Pope's hat. I'm like, I don't see it. Maybe I need to look at more pictures of the Pope and more pictures of the heart, but I don't think it really looks like a Pope's hat, but somebody thinks it does. And so it's also known as the mitral valve as well.
I can low-key see it though. Like,
yeah. There's also like this atria ventricle thing is really important. And we're going to talk about this like signal transduction a little bit more in depth, but I think it's really important for you to understand that like the atria has to contract and push blood into the ventricles. And then while the atria is still contracted, the ventricle contracts, right? And so that pushes blood kind of like forward, right? Imagine that you have like a tube of toothpaste, right? If you just grab it like right in the middle, like everything, like toothpaste is going to go up and down. Or let's say you had a tube of toothpaste that was like, 4 foot long, which is weird. But if you like grab the middle, like it's going to go one direction or in both directions if you just grabbed in the center. But if you grabbed and then right below your hands, you grabbed again, that's going to squeeze things all in the same direction, right? And the valves also play a role in this. The tricuspid, bicuspid is important. There are 2 other valves. There's the pulmonary and aortic valves, but those should make sense. That's the one going to the pulmonary arteries and the one going to the aorta. So hopefully that kind of like makes sense as you know those 4 different valves.
Yeah. And if you think about it in slow motion, right? You squeeze the atrium, and so the ventricle is filling. And so when you squeeze again the ventricle, it's going to push out what it needs to push out. And so it's this kind of quick alternating scenario. So just if you think about it, right? Squish, fill, squish, push out.
Yeah. And that's like, it has to be that way. And that's why your heart beats, like when you listen to it, it's like lub dub, because it's like squeeze, 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 squeeze. If like your whole heart all contracted at the same time, like that would push blood backwards and forwards. And it would just like, if that the whole heart just squeezed, like you would never get any directionality to this blood flow. So we need the atria and then the ventricle always kind of in that order. There's a lot of diseases or problems when like those get out of whack. There's also issues with like if certain valves aren't working, like let's say a valve is like kind of like partially blocked and so blood can't leave, right? Could be like aortic stenosis. Or you could have a place where a valve like doesn't close fully and so blood goes forward and then it can come back, right? And so that would be like a regurgitation. You could have like a pulmonary regurgitation. And these are things that you're gonna like when you get to med school, you'll need to be able to identify, even just by like using a stethoscope, right? Like you can actually just like listen to somebody's chest in different places and you can like figure out if they have like mitral regurgitation or, pulmonary like stenosis, or you're like hearing weird stuff with the blood vessels. And so you really need to know these things well for medicine. Like you are going to be like diagnosing and identifying things by like listening to the blood moving around in people's chest. And like you put the stethoscope in different places, you can hear different valves. And so you definitely want to make sure that you know this for medical school, but obviously it's on the MCAT as well. You're not going to have to like listen to something obviously on the MCAT and like diagnose, but you do need to understand kind of how these things all work together. Now, if we go to like a small scale, right, we like zoom in on like an individual cell, right? Like obviously the heart is cardiac muscle, right? Like heart muscle. And so cardiac muscles are a little bit weird compared to other muscles in your body. They are striated, just like skeletal muscle. And they are kind of like weirdly branched. Generally, they have one nucleus, but sometimes they have two. And that's partially because of like the way a cardiac muscle works, right? We need we need everything to fire all together, right? We need our heart to be very coordinated in the way that it works, right? That's not necessarily true with like the bicep, right? Like when I'm flexing my bicep, I need to be able to flex just part of my bicep, like some cells or more cells, depending on like, am I trying to pick up like a duckling or am I trying to pick up like a boulder, right? And so like I need to be able to like activate it at different levels. Your heart pretty much like you need it to like everything to fire all together at once. And so the way the heart does this is the heart has what we call gap junctions. And so the cytoplasm or like the cells, like between the cells, the membranes between two heart cells, there's like a big pore, like a gap where stuff in one cytoplasm just flows into the other cytoplasm. And it's really weird because kind of your heart has like one cytoplasm because it's like continuous between all the heart cells. And so what happens is like, just like skeletal muscle, like the hearts fire by depolarizing, but because their cytoplasm is all continuous, when one cell depolarizes like that, like the calcium and sodium that like rush in, like drift into the nearby cells. And so they contract as well. And then that drifts into other cells and they contract. And so because the cytoplasm is continuous, that means they all kind of work together, which is super awesome. I will say there's a downside to this because if one heart cell like dies or apoptoses, like a lot of those signaling things can spread into other nearby heart cells, which is why like heart attacks are so serious, because even like if you just stop blood flow to even just like some cells in the heart, like that can spread and you can end up with a very large area of necrotic tissue. Now there's things that we can do to kind of like fight that with drugs, which is why like if you're having a heart attack, get to the hospital, because that can kind of like slow and stop that spreading of death within your heart cells. I don't think there was anyone out there who was wondering like, if I'm having a heart attack, should I go to the hospital? But just in case you were, do go to the hospital. I think that's pretty straightforward overall. So
I think we should have a duckling at during one of our podcasts. No, but yeah, this is really important to keep in mind, right? I also want to make just kind of not a plug, but more of a reminder that heart attacks can present differently in men and women, right? And so just kind of keep that in mind when you are a future physician, because it tends to get underdiagnosed in women as a result of this. But enough of that. Also a reminder that the action potential in cardiac muscle is different than the action potentials, just a little bit, that you've studied elsewhere. So remember to review that. The shape is different, right? So
yeah, if you're looking at like the electric monitoring, it's like an EKG is a little bit different. Or that's an electrocardiogram. I think that's what you're talking about, right? Or are you talking about like at the level of like which ions are moving? And
yes.
Yeah. And yeah, there is some difference there as well with a lot of like more calcium in the musculature. We've talked about like that in one of the past episodes, though.
I believe so.
Like what happens with like muscle activation.
Exactly. Yes, we have talked about that. So we've been talking a lot about signals in the heart, right? And what's really cool is that unlike other muscles, the heart can just pump by itself, right? It doesn't need an initial signal. There is not something that is constantly telling your heart, aside from the heart, beat, 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 because that would be very problematic, right? So the heart is actually able to produce its own signals and tell the rest of the heart, right? It starts in one place, tell the rest of the heart, go, right? So there's this electrical pathway that occurs in the heart, and that's going to start off at the sinoatrial node. And so that's the SA node. And this SA node sends the signal to other parts of the heart, hey, it's time to contract. And so this can actually, so it works on its own, but it's also going to, it can be affected by different parts of your nervous system. So the sympathetic nervous system, fight or flight, can cause your heart to contract more. If the parasympathetic nervous system, the rest and digest, is activated, then it will tell your heart, right? It will cause your sinus atrium, the SA node, to not activate as much. So the heart does its own thing, but it also has to listen to signals from elsewhere in the body, right? That's like you were saying, Phil, if a bear is coming at us, right, we need to know, hey, we need to increase our cardiac output. We need to increase the amount of blood flowing in general, right? It needs to flow faster. And so our heart rate is going to speed up, right? You want it to speed up. It's a little problematic if you're just nervous and not actually being followed by a bear, but the heart does need to listen to signals in the body. So then
I always think about like you meet eyes with somebody across the room who's attractive and like you're young and like my heart rate starts beating faster because my brain is sending signals like, oh my gosh, like they're looking at me. What do I do? And so like that like can affect your heart rate, but you're right. Like the heart will beat just on its own. I don't know if you watch any of those old Kung Fu movies, but like one of my favorites, I can't even remember which one it is, but like there's a Kung Fu guy that like reaches into somebody's chest and pulls out their heart, and the heart's like still beating in their hands. I think they did that again also in like Dumb and Dumber. They like mimicked it there, but I feel like that's been in several Kung Fu movies. And there's something to that. Like the heart will beat on its own, even if it's removed from the body, as long as it's got glucose and oxygen getting into the tissues, the heart will just continue beating just on its own. Even just like some cells, like you can carve out some cells and put it into a petri dish, and those cells will still contract on their own, which is creepy and weird, but kind of cool.
And this ability to contract on its own is like so important. If you think about heart transplants, if you think about eventually one day, I know that there are, and this has been going on since like I was in middle school or high school. So it's been a hot second, but trying to grow cardiac tissue for plant transplants. So all of this is super important that this ability be maintained. So it's just like this really fun characteristic that's also really important for the science behind how the heart works and how we try and fix it.
Yeah, just to relate that to another thing. So with like if you needed the signals from your brain to get your heart to beat, then anyone who became paralyzed and couldn't get signals down to like below their neck, their heart would stop beating and they would die. And so that would mean like becoming a quadriplegic is 100% fatal all the time. And like, that's not the case, because the heart will beat on its own, even without the signals from the brain, which is good if you have like, imagine you get like a concussion or swelling in the brain and that like causes issues with like, like getting signals to the heart, your heart's going to keep beating, even if your brain is like a little bit messed up from like a traumatic brain injury or something like that.
Yeah. So now you've had this first signal, right? And I think of S as in superior. That kind of helps me remember that the SA node comes first. And so now it needs to keep traveling, right? And so now it's going to travel to the atrioventricular AV node. And so remember, we said A comes before V. So that can help us remember that the AV node, right? We're finally getting to V, comes after the SA node. So now we've made it there. We're going to then travel into the bundle of His, and that's going to go between the two ventricles. And from there, we kind of spread out into other parts of the heart through the rest of the ventricles with the Purkinje fibers. So essentially, right, you're having this starting at the top, S, right? SA node signals to the AV node. We finally made it to the V, right? Bundle of His, and then out through the Purkinje fibers. And so that way, all parts of the heart get the signal to contract. And that helps us remember that the atria contract and then the ventricles contract, right? And that can help us remember that we need this squeeze, 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 right? Lub dub. And it's just another way to remember how all of these things are connected.
Yeah. A lot of times people get like kind of confused by the sinoatrial, like what exactly that means. So a sinus is anytime you have like just kind of an empty space or a gap. Like we have several in our face, right? Like our maxillary and frontal sinuses. People say, oh, I've got a sinus infection. Like just like there's some bacteria that has gotten into those sinuses that are connected to your, like through your like respiratory system, like through your nose, right? But there are sinuses other places in the body, including there's like this weird gap like on the back of the heart, this weird pocket that we call the sinus of the heart. It's obviously not connected to your nose. It's just this weird gap, but it's on the atria. And so there's this spot, which is where the signal originates, right? Like the SA node. And we call it that because it's at like that area where the sinus and the atria are together. And so that also explains why it's the atria that contracts first. And so those cells, the SA node cells, are kind of special because they are the ones that are actually starting the signal. They're often called the pacemaker cells. And so once they do that, there's technically like heart cells. And so they got the like gap junctions. And so the signal spreads into the rest of the atria, and like the whole atria, both right and left, all contract together. Between the atria and the ventricle, we need like one to squeeze and then the other. So between the atria and the ventricle, we have to like not let that signal, we don't want the whole thing to squeeze all at the same time. So especially when you get into med school and you're doing like dissections, you'll notice that there's kind of like a thick, it almost looks like cartilage, kind of a rubbery layer between the atria and the ventricle. And that is actually like, it's not heart cells. Like it's not cardiac, it is heart cells, but it's not cardiac muscle. And so there's no gap junctions. And so most of the atria is not connected to the ventricles. And so that causes the atria to all contract together. But the AV node is actually cardiac muscle. And it's like this one space right in the middle of the heart where the atria above and the ventricles below like are connected. But the AV node slows down the signal. It doesn't, the signal can't travel through that fast in the AV node cells. And so that's why the atria all contracts. And then it's like, it takes like a moment before the signal can get into the ventricles. But like, it's kind of tricky. So the atria is a lot smaller in terms of, volume, but also like the walls and like the number of heart cells in the atria is a lot less. Because if you think about it, the atria's job is to pump the blood into the ventricles, right? The ventricle's job is to pump the blood through the entire body and through the lungs. And so the ventricles need to be able to squeeze a whole lot harder than the atria do. The atria like doesn't actually need that much. And so in order to get all of the ventricles to contract together, you have to speed up the signal through the ventricles. And so there's specialized cells that carry the signal. Just like the signal was slowed down in the AV node, we like after we do that pause, we need to speed it up and spread it throughout the ventricles really quickly. And so that's where the bundle of His and the Purkinje fibers come in. And so you can kind of think about the bundle of, like, I always think of like a highway with off ramps. And so these are like ways to like send signal real fast. And so there's the bundle of His, which is basically a lot of these like pathways all together. And then they branch out into all these other like smaller pathways that kind of like go into the rest of the ventricles. But it's really interesting looking at like the signal transduction and how the signal kind of moves through there, where it like goes all throughout the atria. I keep wanting to say aorta. It goes all throughout the atria first, and that's fairly quick. And then it's slowed down at the AV node and then accelerated in the bundle of His and Purkinje fibers. And so that allows us the atria pause and then ventricles to contract. So that kind of a cellular level, like trying to understand how this all works, is pretty cool. Now we can also just straight up measure like that that signal being sent, right? We can measure what happens with the electric fields in there. And that's what happens with like an EKG or electrocardiogram, where there's like, you stick like electrodes all over somebody's body and you like measure kind of like what's going on. And that's like what most people are familiar with. Like, you know, you go in a hospital and there's like the monitor over there and there's like the beep, beep, and it like shows like the weird kind of like jagged lightning bolt looking thing. But that's just trying to show like graphically what's happening with the movement of that action potential, the movement of that like signal being sent through there. And there's, once again, there's all sorts of things where people have heart attacks and like parts of the heart will die in different areas. And so obviously signal can't be sent through those areas. And you can like straight up just look at an EKG, especially ones that have a lot more data, like the 12 lead EKG, which has like tons of information from it. You can not only see if there's a problem, but you can figure out where the problem is, right? Like this is a problem that's like there's cell death on like the anterior left bottom quadrant of the left ventricle, right? Like you can like start to figure out where the thing is, and you can identify what artery is being blocked here so that there's heart cells dying. And so that's something that you will eventually be able to do. And like diagnosing stuff just by looking at an EKG is really interesting. Like, as I said, there's also this like signal being sent down from the nervous system, but your heart also will respond to hormones, right? And so epinephrine from like a neuron will make your heart beat faster, right? Like, you know, you see somebody attractive across the room and like they meet your eyes, you know, you have someone you have a crush on, but like it also happens like hormonally, right? So epinephrine can also be released from like your adrenal glands. Right. I want to be clear here. Epinephrine is a neurotransmitter and a hormone, right? Because it's released from neurons and it's released by endocrine glands into the blood system, right? And then signals happen that way as well. And so there are times that signal like from the vascular system will also increase your heart rate. Once again, there's also things like places where things can go wrong. There are people who are getting signals like neurologically that's telling their heart to beat faster in a pathologic way. And so you can actually go in and then just like burn those neurons and just like stop that signal. And so then if somebody like neurologically is like trying to increase their heart rate, that may not actually work very well, but their heart will still increase like endocrinologically. Whew, that's a word. If you spell in Scrabble, you'll win. Endocrinologically. So your endocrine system can still work in that case, even though your neurological system is, you're kind of messing with. There's also obviously problems where like your heart's not beating right anyway. And then you might put in like an actual pacemaker that like shocks the heart. And whenever you shock the heart, everything squeezes together. So if you have like for some reason, like parts of the heart are contracting and like fluttering or like not contracting together due to some problem with that like signal, sometimes you can just reset the heart by shocking it. And that's what you see in like the movies when they're like clear and then chunk and like shock somebody across their chest. The idea there is they're trying to get the heart back in like a normal rhythm instead of like a messed up rhythm kind of overall.
Yeah. And it's helpful to think about, like you said, also the other connections with what you guys will be seeing. And part of that is we've been talking a lot about the heart itself. To your point earlier, a lot of issues also come from the vessels, problems with the vessels. And so something we haven't talked about is that the heart has its own blood supply. And so problems with that blood supply can lead to problems with the heart's ability to contract. And part of that is what you were saying with a heart attack, right? And so there are different things that we can do for it, but I think it's also important to think about the mechanism of how the heart, those vessels narrowing affect its ability to contract. And so,
yeah, it's kind of weird because I feel like, at least for me, I just assumed that when the blood came back from the lungs into the heart, that like the blood flowing through the heart was oxygenating it, but that's not the case, right? Like the blood, after it goes into the aorta, there's some arteries that branch off and go back to the heart itself. And so the heart is not being oxygenated by the blood flowing inside the heart. It's being oxygenated by arteries that have branched off the aorta and come back around the outside and start to oxygenate it there. And so if those become blocked, you got problems, and that like some pretty severe problems that you need to get addressed.
Yeah. And so some of the ways that those can be addressed is like a stent. And so they can put a stent into those arteries in order to keep them open. But something else that they can do that's really cool is like a graft from an artery from a different part of your body and bring that into the heart. Because if you think about it, once that's narrowed, it's narrowed, right? There's not a whole lot that you can do about it, aside from something like, a stent and whatnot. So something that they've done very often is called, and you do not need to know this for the MCAT, this is just a fun fact, a CABG, a coronary artery bypass graft. And so they will take an artery from elsewhere in your body and put it on the heart, which I personally think is really cool.
Yeah, they'll take like an artery from like your arm or your leg, and they'll like just like stitch it, Frankenstein it back into the heart. So now there's like a new artery that you just kind of like built into this. And so if there's an occluded place, like a blockage, you can just go around it through this new artery you put on. Just in case someone doesn't know what a stent is like basically you can kind of think about it as like a pipe that expands. And so like you take this pipe when it's like really small, you stick it in like the area that's narrow, and then you expand it, and it like pushes open and inflates that area.
Yeah. And it's like this little mesh. Did you ever play with those little mesh pipes?
Yeah.
You
The
put your finger in and you can't. Yeah.
The finger traps. That's exactly what it's like, where
there we go.
Like, it's like thin and narrow, and then it like expands, and it's this weird like mesh network that works in a way.
And what's really cool is that they've actually created stents that have drugs in them. And that's a drug-eluting stent. And so, the fact that they've tried to figure out so many ways to address heart problems just tells you, and just goes to show that it's a common issue, right? And it's something you have to act on. You have to do something about it, because you can't live without your heart.
Right? Exactly. Like it's still to this day the number one cause of death of Americans. And like, that's something that, if you are a doctor and you have a patient, probably the most likely thing to kill them is a heart thing. Like that's just the most likely thing. And so you definitely want to make sure you know what's going on with that. There's some like issues, like sometimes stents won't work, right? And that's when you have to do a CABG. Maybe sometimes stents can like damage blood vessels as they travel through, at least, especially the older ones. The newer ones are way better than the older ones. But even then, sometimes an artery will become so filled with plaque and like calcified that it like you can't expand it, right? It's like so hard and hardened that there's no way to kind of open that. I have this like really strong memory of when I was starting in med school, and like the first 6 months I was there, that like there was during the cadaver dissections, there was an artery that I removed. It was the aorta, and it was so calcified that like I could have used that aorta as a hammer and drive a nail into a board, right? Like I could not squeeze it at all. It was like an iron pipe. Like it was so hard and calcified. I definitely like after that went on a thing and like, okay, I'm going to quit eating red meat and I'm going to take fish oil pills. And like that lasted for like about a year, where I'm just like, okay, like I don't want my arteries to look like that. And like, it kind of scared me. I wish that that's one of those things that like this is happening kind of inside people all the time, and we're just not aware of it. I think if people saw what's happening, like what happens to your arteries, or at least had a better idea of like visualizing that, I honestly think, at least for me, it made me try to be a little bit healthier. And it's still something that I'm like, I should get back into jogging, not necessarily because I want to like lose weight and be fitter, like in that case, and like look nicer, but I'm just like, I want to be healthy in my like 60s and 70s. And like the way you do that is by exercising and eating right and doing things like that. My cardio teacher in med school was like 70 when he was teaching, but he still went and swam like like, I think it was like over a mile every single day. Like every morning he'd get up and swim. And I'm just like this 70-year-old is more fit than I am. And I think that it's probably because he was constantly going in and looking at hearts and like those sorts of things. And so he's just like, I got to take care of my heart. And so, so as a result, like I still think about him like to this day. I'm like, I wonder where he is. He's probably in his 80s now and still probably fitter than I am. But definitely kind of an interesting thing.
Yeah. Now might be a good time. Check your pulse. Make sure your heart is still beating.
Yeah.
And thank you for joining us.